I'm going to introduce the next scientific session, Quality and General Surgery. First, Dr. Raquel Gonzalez is an assistant professor of surgery, section chief of surgical critical care and surgical critical care fellowship program director at Johns Hopkins All Children's Hospital in St. Petersburg, Florida. Dr. Pamela Choi is an associate professor of surgery and incoming program director of general surgery at the Naval Medical Center in San Diego. And Suhail Zenadine, is a resident physician in the Division of Pediatric Surgery at Lurie Children's Hospital in Chicago. Thank you.
You got it, Pam? All right. I'm doing the evens, right? Yep, you did.
All right, we'll start with Dr. Short from University of Utah with cessation of antibiotics for perforated appendicitis at discharge does not increase risk of postoperative infection.
And thank you for the opportunity at the podium. We have no disclosures. Just as some background, I think all of us recognize that the use of antibiotic therapy in children with complicated appendicitis is inconsistent and varies widely by institution. If you look at this recent snapshot from the PEDS NSQIP SAR, where the y-axis is home oral antibiotics given at discharge and the x-axis is institution, you see there's dramatic variability from as high as nearly 100% to as low as close to 0%. This is driven partially by lack of consensus with both antibiotic choice, duration, and use, and is driven by an overall lack of high-quality studies in the literature. At our institution, we utilize protocols for management of our children with complicated appendicitis, and in 2019, we amended this protocol to stop discharging children with antibiotics following their surgery for ruptured appendicitis. And we hypothesized that we decrease their antibiotic exposure without changing their morbidity. And to evaluate this, we looked at our institutional NSQIP database from 2015 to 2022 and looked at all children who underwent an appendectomy for complicated appendicitis as defined by the pediatric NSQIP. And we defined two cohorts, those who were discharged home with antibiotics and those in the time period where the protocol did not include home discharge with antibiotics. In both groups, they received IV ceftriaxone and metronidazole while hospitalized, and they were discharged home when they met clinical criteria. There was no prescriptive time duration in the hospital. In the home antibiotic group, we saw them back on post-op day 7 with a white count CRP. If their labs normalized, we stopped their antibiotics. If they weren't normal, they got another week of antibiotics and saw us again. In the no home antibiotic group, we simply stopped their antibiotics. There was no additional lab work, and we saw them in a single follow-up date in 1 to 2 weeks. We evaluated and compared both groups with regard to their demographic and clinical factors and focused primarily on postoperative outcomes, including surgical site infection, need for percutaneous drainage, reoperation, their length of stay, ER visits, use of postoperative imaging, and readmission rates, and utilized standardized statistical techniques. Overall, we identified 306 children. There were 185 in the home antibiotic protocol group. 83% of these children were discharged on protocol with antibiotics. In the no home antibiotic protocol time period, we identified 121 children, and 92% of which were discharged off antibiotics. And all children had at least 30 days documented follow-up. So importantly, between those two groups, we found no difference in age, gender, race, weight, white count, ASA score, OR time. In our no home antibiotic group, there was a trend towards a decreased rate of documented SIRS at 60% versus 75%. But more importantly, when we looked at our postoperative outcomes, we really found no differences across the board. Are any infection rates the same? Are SSI rates the same? Are organ space infection rates the same? Are ER visit rates the same? Are imaging utilization was the same? The need for readmission was the same. And importantly, our length of stay was not statistically different, but actually trended shorter. We were also interested at looking to try to understand if there were differences between those that developed an SSI versus those who didn't. So when we looked at the entire cohort, for both time periods and compared SSI to no SSI, we found that they had similar age, gender, weight, white count, OR time. Those with SSI stayed longer, but both groups had similar rates of discharge antibiotics and did not appear to be affected by its use. So our findings support cessation of antibiotics at time of discharge following appendectomy for ruptured appendicitis. There was no increase in infectious complications, no difference in length of stay. We feel continuation of antibiotic therapy may be unnecessary, it may offer little benefit, and may confer risk of antibiotic-related complications. And this is supported by several studies in the literature. Matei and colleagues looked at their review of 363 children where they discharged patients based on surgeon preference with and without antibiotics. Antibiotics were not found to be protective. The APIC trial out of Europe, which enrolled more than 1,000 patients in a prospective fashion, found that 2 days of antibiotics was not inferior to 5. So in conclusion, following our protocol, we found no changes in morbidity. We're limited by our retrospective nature and sample size, and our findings suggest that we should stop utilizing antibiotics following discharge. Thank you, and I'll take any questions.
Just to clarify, in your protocol, so it did not matter what the length of antibiotic duration was prior to discharge if they were, only received 3 days of IV antibiotics versus like 7 days of IV antibiotics?
That's correct. The children were sent home when they were able to take adequate oral intake. Our median length of stay for all kids was 4 days, but there was no prescriptive time duration.
Yeah, I was going to ask, so what were the exact discharge criteria for the study?
So basically, they have to be able to tolerate adequate oral intake to maintain their hydration and nutrition, and that really is our discharge criteria.
Yeah, along those same lines then. So fever, they went home with a fever, they went home with pain. That was not a factor at all.
So I think certainly there's some clinical judgment there, and the way our protocol is designed is to get kids home early. I think if a provider is concerned about those things, that may keep a child in the hospital. A little bit limited by looking through the NSQIP data in that view. Fevers are not an indication for us to keep kids in the hospital. Certainly uncontrolled pain would. So I suppose I should amend my statement.
Sharif Emile, Montreal. Thank you. This is really wonderful work, and hopefully it puts to rest a controversial issue. It certainly validates what we've been doing in Montreal for over 3 decades. Patients go home without any additional antibiotics. I would just make a plea, the problem with a lot of what we're doing in appendicitis research, even using the NSQIP definition, is we're making it a binary disease. Is it complicated or is it not complicated, despite the definition? And perforated appendicitis is not a binary disease by all means. It is a continuum, from early perforation to generalized peritonitis with abscess. And I think in every study we do, we really have to start dissecting out these risk groups, because there's certainly increased risk for complications as you increase the stage of appendicitis. And I would just make a plea that we take this into account as we continue to look at other issues that are still controversial. Thank you.
Thank you.
Thank you.
Our next presenter is Dr. He from Boston Children's Hospital. She'll be talking about same-day discharge and the value proposition in children undergoing appendectomy for uncomplicated appendicitis. The devil is in the details.
Thank you for the opportunity to present our work. Use of same-day discharge protocols following appendectomy have become increasingly common and are associated with lower resource utilization and greater patient satisfaction without increased rates of hospital revisits. However, relative value associated with same-day discharge protocols may differ based on relative use of inpatient services, such as inpatient ward and nursing charges and extended PACU utilization. We hypothesize that the relative value of same-day discharge may differ based on these factors. With these considerations, the objective of the study was to assess hospital charges associated with same-day discharge for patients with uncomplicated appendicitis for different throughput pathways from ED presentation to discharge. A clinical protocol was implemented at a single children's hospital to facilitate same-day discharge for children undergoing appendectomy for uncomplicated appendicitis. Patients who were discharged on the same calendar day as incision closure were considered same-day discharge. Prior to the protocol, patients were routinely discharged on a day after appendectomy. Data were retrospectively collected via chart review over a 12-month pre-intervention and 32-month post-intervention period. We defined 3 throughput pathways based on relative utilization of inpatient services. The first comprised patients who were admitted to the inpatient ward pre- and post-operatively. The second comprised patients who were only admitted to the inpatient ward post-operatively. And the third comprised patients who were discharged directly from the PACU without use of any inpatient services. Charges were compared for the care locations that would be plausibly impacted by the protocol, including operating room, PACU, and the inpatient ward. Length of stay was assessed over the entire hospitalization as well as for the PACU stay, which at our institution is billed in time-based increments. Charges and length of stay were compared on 2 levels. First, between pre-protocol and post-protocol implementation groups to assess the effect of same-day discharge implementation. Next, between each of the 3 throughput same-day discharge pathways. Over 1,000 patients undergoing appendectomy were included in the study, 268 prior to the protocol and 777 after. The breakdown by same-day discharge pathway is illustrated here. Mean charges by month before and after same-day discharge implementation are illustrated in this slide. The post-implementation group is in gray. Aggregate OR, PACU, and inpatient charges are on the left, and OR charges are on the right. Following protocol implementation, aggregate charges decreased by $806 per patient. OR charges remained unchanged, suggesting similar disease severity between comparison groups. Following same-day discharge implementation, inpatient nursing and ward charges on the left decreased, as we expected. However, we also found that PACU charges increased by 28%. Total length of stay decreased following implementation of the protocol, as we expected. However, PACU length of stay increased by 40%, accounting for the increase in PACU charges. This slide illustrates variation in hospital charge categories for different pathways. Median charges are on the y-axis and hospital location is on the x-axis. Operative charges were similar between pathways, suggesting disease severity was similar between groups. Direct discharge from the PACU, represented in the light blue, was associated with higher PACU charges, although an overall net savings due to avoiding inpatient services. Pre- and post-operative admission was associated with the highest overall charges due to accumulation of inpatient ward and nursing charges. The PACU length of stay differed significantly between pathways, and direct PACU discharge was associated with a greater 2-fold increase in PACU length of stay. The increased PACU stay associated with direct PACU discharge amounted to an average difference of $643 per case as compared to patients discharged from the inpatient ward. As compared to direct PACU discharge, post-operative inpatient admission was associated with a greater than $800 increase in charges, and pre- and post-operative admission was associated with a greater than $2,000 increase in charges. Based on the billing structure at our hospital, the relative value of direct PACU discharge would be eliminated after 85 additional minutes as compared to post-operative admission, and after 211 additional minutes when compared to pre- and post-operative admission. In conclusion, relative value associated with same-day discharge was significantly impacted by admission pathway. Strategies to optimize value may include avoiding inpatient admission to eliminate ward and nursing services and avoiding prolonged PACU stays. Thank you for the opportunity to present, and I welcome your questions.
Kirk Reichert from Wilmington. Very nice talk. We've been doing this for a while too. I was curious if you were able to determine what caused that increase in PACU stay, and that may sound like a stupid question, but one of the things we found was that pain was an issue, and when we started doing blocks in every child pre-op, which we now do, we dropped the PACU stay by quite a bit. So just curious what you found.
I think it's a fantastic question in terms of how to reduce these prolonged PACU stays. Although we didn't investigate this specifically at our institution, which is something that we hope to do further, the literature demonstrates that there are non-clinical and clinical factors that are associated with extended PACU stay, and that includes, as you said, management of pain and then management of postoperative nausea and vomiting. And so some of the strategies that one can use would be intraoperative administration of ketorolac or Tylenol, dexamethasone, 5-HT antagonists, or total intravenous anesthesia. And some of the non-clinical factors include administration of medications, and so some of the factors that can be influencing that would be allowing nurses to determine the discharge criteria, as well as allowing pharmacy to pre-approve certain medications for the PACU without needing for those additional orders.
I have a question from the chat. They're asking, do you have a fourth pathway? Were there patients who were admitted to the ward, then went to the OR, but then got discharged from the PACU without having to go back to the floor?
One of the criteria when we were setting up the same-day discharge protocols is that admission to the inpatient ward preoperatively would exclude them from being able to be discharged from the PACU.
Steve Stylianos from New York. As you calculated your value proposition, did you take into account the fact that you left a med-surg bed open that could be used, sold to another customer, and that enhanced the revenue of the day?
That's an excellent question, and the consideration of the opportunity cost associated where the patient is a big consideration. It's not something that we included in our study, but one of our recommendations to avoiding inpatient stays would be collaborating with your ED colleagues if the patient's coming from the ED to discuss whether or not direct transfer from the ED to the preoperative area was feasible. That is to say, if prolonged ED boarding would be an option and wouldn't cause too much opportunity cost for other patients that needed care in the ED. So I think it's a very important consideration to take into account.
Dr. He, quick question. Where did you, which pathway is the observation patient in? So we have an observation unit. Which pathway would we look at to mirror those costs?
I think that's a fantastic question, is how can we translate these methodologies to different institutions? And I think more than just looking at what's happening in your observation group, you have to look at how are hospital stays billed in aggregate in your hospital. So for example, our PACU time is time-based increments. So each minute you're there, in addition to a sunk cost, you're accruing charges. Whereas the ED is more of a severity-based charge based on your level of care, and the inpatient stay is based on an 8-hour cost. So really you have to look at how all of these things are billed. And then for your specific hospital and your specific pathways, assess how much time patients are spending in each one and how much it does cost.
All right, thank you so much. Our next abstract is Dr. Olutoye from Baylor University, Academic Productivity of APSA Foundation Grant Recipients.
Thank you for the opportunity to present. I have nothing to disclose. The number of surgeon scientists has been declining due to competing administrative demands, lack of departmental support, and pressures of clinical volume. Interestingly, in addition to these obstacles, the competitive funding environment is a significant burden to these surgeon scientists, as the success rate for surgeon scientists concerning NIH grants with surgeons as principal investigators is only 16.4%. Fortunately, many surgical societies offer grants to foster the development of these surgeon scientists, and these grants allow surgeon scientists time away from clinical studies or clinical duties in order to focus on their research and offset the financial burdens on their departments and on their mentors. For junior faculty, these awards are provided in a critical period in the awardees' careers and serve as catalysts for further research and as seed funding for those looking to jumpstart their research careers and build on their goals of academic advancement with the hopes of receiving further grants, such as NIH awards. With this in mind, we sought to evaluate the academic success for junior faculty who received the J. Grossfeld, MD Scholar Grant in APSA. We took a look at awardees who received the award from 1996 to 2022, and we assessed their demographics as well as their scholarly achievements. We looked at their publications, H indices, citations, NIH grants awarded, and we got this information from their publicly available institutional profiles, Google Scholar, Scopus, PubMed, and the NIH Reporter. When looking at their demographics, we saw that, well, first we saw 47 awardees on the APSA website that were obtained from the list of past award winners. 36% of them were female, which is congruent with the population of APSA, with the most recent DEI survey showing that 34% of APSA members identify as female. 17% of these awardees had advanced degrees in MD, MBA, or MD, PhD, and 38% of them had reached full professorship at the time of the study. 30% of them were division chiefs, and 15% had obtained a chair position. A median of 1,400 citations were had by each awardee, or by the awardees, and the median H index was 21. As a reference, a recent paper out of UAB shows that those who have recently been promoted in their surgery department to assistant professor have average H-index of 11, while those being promoted to full professor have an average H-index of 17. 11% of them received a KO8 following their J. Grossfeld Scholar Grant, and 15% of them obtained an R01. The KO8 to R01 conversion rate was about 40%. And when looking at all NIH grants obtained by this group of awardees, we see that 32% of the awardees had received or obtained an NIH grant following their award. This led to $157 million in NIH funding by the awardees, and this is about a 159-fold return on investment. So some limitations of our study. This study is limited in our definition of academic success, in which we only take a look at publications and leadership roles as success, but we are well aware that there are many more factors that go into academic success, such as teaching, for instance. We don't have a solid comparison group. An ideal comparison group for us would be those who applied for the award but did not obtain it. However, we weren't able to gain access to that information. What we show here is association, not causation, and there is lead time bias, in where those who received the award back in 1996 would most likely have achieved higher levels of academic success as compared to those who received it 3 to 5 years ago. Next steps of this project will be to send individual surveys to those who have received the award to obtain more detailed information on the factors that influence their success. So if you're in the crowd and you previously received the award, be on the lookout for a survey. And so what does this mean? A, the selection process for the J. Grossfeld grant selects those who are likely to succeed, or B, the J. Grossfeld grant is a catalyst for academic success, or both. What we do know is that a high percentage of these faculty go on to hold leadership positions and receive NIH funding. Thank you, and I'll be happy to take any questions.
Steve Stylianos, New York City. Thank you for bringing this to the membership. I think it's very valuable for everyone to see it on the screen. Many of us who have served the foundation recognize this. We've polled many of the individuals who not only said that the monetary value was important, but it validated their position in their institutions as bona fide investigators. The return on investment, which you showed, should take away any doubt of anybody in this room that it would be valuable to donate to the APSA Foundation. And thank you for bringing that to us.
Thank you for your comment.
Yeah, thanks so much for this report. You know, certainly there's a lot of prominent people who have been Grossfeld scholars. My question is kind of what you've alluded to. You know, do you have any thoughts about if this award just chooses people who are likely to succeed anyway, and how are we choosing people who receive this award? Are they people who are likely going to succeed anyway, or are they coming from places where they generally could benefit from the additional financial support because they're not from a traditional large institution, large academic institution?
Thank you for that question. And it's really hard to say without having more information. And I think the survey that we plan on sending out will collect a lot more of this information that we think will speak to both the experience of the awardee after they've received their award, and also where that awardee stands prior to receiving their award. And so I think we'll be able to get more answers from that.
Gail Besner from Nationwide Children's Hospital. Thanks for that really wonderful presentation. This is just one of the incredible things that J. Grossfeld did for pediatric surgery, and I can't speak highly enough about this award because it's demonstration to your institution that you're getting your foot in the door. My question is, over the many years that this award has been given, have you noticed, was there a change from the ratio of basic science awards to clinical research awards over the years? It seems that there's been a transition in that direction, and I'm wondering if that was paralleled by this award process. Thank you.
Thank you for your question. So when the information we're able to gather is kind of a snapshot, and so the type of research that that the person is doing currently. But when we send out our survey, we'll be able to really understand the type of research that the awardee was doing at the time that they received their award and how that's changed over time. And with that, we'll have a better idea of whether they're doing basic science or clinical, whether they started off as basics and are now doing clinical, or vice versa.
All right, thank you so much.
Our next presenter is Dr. Sajan Kila from Nationwide Children's Hospital.
I'm a pediatric surgery research fellow at Nationwide Children's Hospital, and I'll be presenting some of our QI work. Health information technology augments a QI-directed morbidity and mortality conference and improves quality of care. We have no relevant disclosures. In 2014, we developed a QI-directed M&M conference, prioritizing discussion of individual and system-level failures, as well as the development of corrective action items to prevent recurrence of those failures. However, due to a reliance on individual electronic documents to store the M&M data, our ability to assess trends in failures and action item implementation was unfortunately hindered. In 2019, we created a secure, searchable, electronic health record integrated web application, or web app, a type of health information technology to store M&M data. In this study, we assess the impact of our web app on efficient review and tracking of M&M data, including system failure occurrence and closure of corrective action items. This is our M&M determination form that we use to guide our QI-directed M&M format. During the conference, we discussed the severity level of the event, whether the event was preventable, if any type of error contributed to the event, and if that error was due to an individual or system-level failure. And in addition, if any corrective action item was assigned to address the failure. Under our classification system for system-level failures, we have 5 different types, including failures due to structure, culture, process, policy and protocol, as well as technology and environment. And as you can see, there are several subcategories. For example, under structure, you have failures due to resource allocation or inadequate collaboration mechanisms in which the resources or the system prevents collaboration from occurring. Under culture, you have issues with non-collaborative behaviors such as defensiveness, lack of teamwork, low morale that might contribute to a lack of collaboration. And under process, there are problems with inadequate system interface, such as a lack of appropriate handoff of information or inadequate checks. And under policy and protocol, issues with lacking policies or problems with usability or understandability of those policies. And finally, under technology and environment, you have environmental issues such as unnecessary noise or commotion. Prior analysis revealed that our unique M&M conference identified system-level failures that were not fully captured by other quality metrics, such as NSQIP Pediatric. Thus, using the web app to augment data collection and analysis, we studied system failure occurrence from 2014 to 2022 to understand the impact of our QI-directed format. In total, between 2014 and 2022, there were 1,694 cases that were reviewed during our M&M conference, and from those, we identified 175 system failures. Here we display the system-level failures from left to right, from most to least frequent by category. And the text in black within each bar represents the number of times each system failure occurred, and the green line shows the cumulative percentage that each of the preceding system failures contributed to the total. As you can see, the top 5 system failures contributed to 79% of all system failures, and this included failures due to lacking or informal policies, inadequate collaboration mechanisms, inadequate system checks, non-collaborative behaviors, and inadequate system interface. As a part of our QI-directed M&M, specific action items are assigned to address each system failure and to prevent repetition of the same failure. And over the 8-year course of the study, we saw a 67% reduction in the occurrence of the most common system failures. In addition to studying changes in system failures using the web app, we also leveraged it to study trends in action item closure. In January of 2021, using the web app, we identified a backlog of unaddressed action items that were developed to reduce failure occurrence. To address this issue, we implemented a QI initiative to reduce the backlog and use the web app to compare action item closure pre- and post-implementation. We utilized a key driver analysis to achieve our goal of increasing on-time closure of action items. And the interventions we developed included setting reminders and alerts, as well as establishing turnaround time for key processes and monitoring the compliance with the M&M form completion. The mean number of open action items per month decreased from 21.7 pre-implementation to 1.4 post-implementation, and this was statistically significant. In fact, increased closure of action items resulted in a significant month-by-month reduction in backlog of action items from a peak of 33 in January 2021 to 1 in December 2022. In conclusion, we have shown that a secure, searchable, EHR-integrated web app can improve the capabilities of a QI-directed M&M process. In fact, it can enhance the efforts to retrospectively and prospectively track trends in errors, failures, and improvements. And using this web app, we were able to demonstrate that our QI-directed M&M process improved system-wide care, and that these improvements included meaningful changes in departmental policies, protocols, and culture, as well as improvements in multidisciplinary communication. Thank you so much. I'd be happy to answer any questions.
Dr. Sajankala, what education is provided to the faculty and to the new fellows as they were getting acquainted, or when you have new staff, to understand these definitions of system failure?
Yeah, so just to backtrack a step before, so there's a nice paper trail for this work. There's 2 papers that precede this. We worked with a separate private firm to develop those definitions. So there's a nice PDF of all the definitions that's easily available to, everyone. And then the other nice thing is that that M&M determination form that we used is used for literally every single case. So if you attend one of our M&M conferences, you'll immediately become very familiar with the process. Yeah.
Thank you. Next question.
Hi, Scott Short from University of Utah. Great presentation. Thank you. Just a couple of kind of brief, simple questions. I think one, having recently gone through the children's site verification in our hospital, I think getting this feedback back not just in general surgery, but the other peds specialties is a challenge. Have you been able to share this with other divisions in your hospital? And then my follow-up question to that is this something that you can share outside your institution, and what EMR systems does this integrate with?
Yeah, so also to backtrack for a second, this was built from the ground up in collaboration with IT people and QI people at Nationwide Children's. So we have a dedicated software programmer that helped us build this. In terms of integration, at least for us, it's integrated with Epic, but again, it's built from scratch. So if you were to make this at your institution, as long as your EMR has the ability to interface with other applications, and most of them do, you'd be able to build something similar to this. And then in terms of sharing within institution, this was general surgery or pediatric surgery was the main initial user, but there are several different departments that are utilizing this simultaneously. And we're beginning to get to the point where we're starting to get some interdisciplinary work between the different groups.
Thank you for your presentation.
Thank you.
All right, next we have Rachel Bank from Case Western Reserve University with the value of a reminder, utilizing patient tracking with pediatric gastrostomy tube patients to decrease emergency room visits.
So now when we think of a hernia, we repair it surgically. The patient carries on with their life after a very brief recovery. When we think of appendicitis, we once again have a very discrete phase of care where we remove the inflamed appendix and the patient returns back to their normal life. For our pediatric G-tube patients, placement of a G-tube is merely the beginning of what may be weeks, months, or even years of learning how to manage a completely new way of feeding for both the child and their caregiver. G-tube patients require long-term maintenance that can lead to complications and ultimately costly emergency room visits. We find that a good number of our extra patient visits or G-tube related emergency room visits revolve around issues with the site, such as infection or tube dislodgement. In order to help combat this, we began to look at Inside Out Care, which is a patient-facing educational platform that serves to provide education for our patients and their caregivers, both pre- and post-operatively. We quickly realized that this program also served as a way to track patients who are undergoing G-tube placement in order to utilize it as a system to remind us, to give patients reminders to schedule their 3-month post-operative follow-up visits. We decided to look at this tracking aspect of Inside Out and utilize it as a way to remind patients to schedule their post-operative follow-up visits. So we looked at the year prior and the year after the implementation of Inside Out Care. Before August 1st of 2020, our patients were reminded verbally on the day of their surgery to schedule a follow-up visit, and there was no organized system in place to remind them further or ensure that they scheduled their visit. Following the implementation of Inside Out Care, we were able to provide a verbal, in-person reminder on the day of their surgery, and then an additional reminder over the phone to schedule their follow-up visit. This phone call was from a nurse practitioner who also served as a resource to answer questions and provide any additional education necessary to the caregivers of our pediatric patients. So our study cohort, we looked at pediatric patients who underwent G-tube placement in the years before and after the implementation of Inside Out Care. We chose to exclude patients who were hospitalized 90 days post-operatively, given the overlap with one of our primary outcomes, which was whether or not patients attended their 3-month post-operative follow-up visit. We ended up with 76 patients in our pre-intervention group and 62 patients in our intervention group. Our first research question was whether provider usage of Inside Out Care as a post-operative tracking system increased attendance at the 3-month educational post-operative visit. We also sought to demonstrate that the 3-month follow-up visit ensures that families receive the education they need to care for their child by reducing the frequency of ED visits in the 3 to 7 month post-operative window. We chose to study the 3 to 7 month post-operative window because there's currently a gap in the literature looking at that time period. The existing literature looking at complications post-pediatric G-tube placement generally only looks at the first 3 months after surgery, and the 3 to 7 months encompasses a new period of independence for the child and their caregiver in the management of their G-tube. We did a retrospective chart review. Data was collected in REDCap, and we used a chi-squared test of association and 2 independent sample t-tests. As far as our results, we found a non-statistically significant increase in attendance at the 3-month educational follow-up visit between the pre-intervention and the intervention group from 68 to 73% attendance. But we did find a statistically significant decrease in the percentage of each group that had at least one G-tube related ER visit in the 3 to 7 month post-operative window. There was also a statistically significant decrease in the average number of ER visits between the 2 groups from 0.48 to 0.21. Further subgroup analysis revealed that our intervention was significantly effective at reducing whether or not patients had at least one ED visit in that 3 to 7 month window in our patients with public insurance. We hypothesized that the phone call was an important outreach step in reaching our patients with public insurance. We also found that patients in the intervention group who had an NG tube prior to G-tube placement were significantly less likely to have at least one ED visit in the 3 to 7 month post-operative window. Ultimately, the group that received a reminder and check-in phone call from our nurse practitioner had fewer ED visits in the 3 to 7 month post-operative window and a non-statistically significant increase in attendance at that 3-month follow-up visit. Prior to the implementation of this software, there was no standard protocol for ensuring patients were contacted. But after the implementation of the software, because we had a member of our pediatric surgery team contacting every patient's guardian to schedule their follow-up visit, we allowed for an organized patient tracking system that potentially reduced costly emergency room visits and provided a valuable opportunity for patient questions to be answered and a resource for patients and their caregivers. Thank you very much. I'm happy to take any questions.
Yeah, thank you so much. I really love the idea of utilizing technology. I mean, we use apps for everything, so why not use it for to help with patient education as well as outcomes. My question was, can you please specify a little bit more information and give us a little bit more information about what exactly does the app do? Does it provide like pictures? Does it provide education, troubleshooting advice, or does it just send out an alert when it's time to schedule for a post-operative visit?
Sure, sure. So the app has 2 main functions that we kind of grouped it into. So the first is that it's a resource both online and on the patient's phone where they can there's answers to common questions pre and post-operatively. It's split into different categories, what type of G-tube, how do I navigate this complication, et cetera. The other function of the app that we found that was actually the driver of this study on our end was that it generated a list of patients that we had signed up for the app. And so we were able to use that list as an organized way of ensuring that those patients were contacted to schedule their 3-month follow-up visits.
And then knowing this data, what would you say are the next steps for the study, and like how would you bring this into the future?
Sure, sure. I mean, I think that something really significant that we found in our study was the impact on our patients with public insurance, because those are the patients who are using the emergency room more, and those are the patients who are often slipping through the cracks, so we really need to make sure are attending these follow-up visits and receiving that care. So further analysis of what exactly is happening in these reminder phone calls with our nurse practitioner and their patients, and what resources and information is helpful to prevent emergency room visits, I think would be the next step in order to figure out how to implement this further.
All right, well, thank you so much for your time.
Thank you.
Next, we have Dr. Hedge from the University of Texas in Houston, speaking about gastrostomy tube preoperative boarding pass for congenital cardiac surgery patient improves days to surgery and hospital discharge.
Thank you for the opportunity to present our work today. I'm presenting on behalf of our research resident, Brittany, who has a brand new baby boy at home and couldn't be here today. We have nothing to disclose. Congenital heart disease affects 1% of live births annually in the United States. Patients with congenital heart disease frequently have feeding difficulties requiring enteral feeding access. At our institution, like many tertiary care centers, cardiac patients are cared for by a multidisciplinary team of providers, including cardiologists, cardiac intensivists, and cardiothoracic surgeons. Non-cardiac surgical procedures in this patient population are risky and it require additional coordination with cardiac anesthesia. It was observed that extensive care coordination and non-standardized diagnostic workup led to delays in care in obtaining surgical enteral access. Thus, we sought to create a uniform diagnostic workup with the goal to decrease the time from consult to G-tube placement and ultimately hospital discharge. First, to address our pre-intervention cardiac G-tube consult process. It's one you guys are all probably quite familiar with. The consult goes to the intern. The fellow then asks the interns a lot of questions that they don't know the answers to. And finally, after a bunch of back and forth with cardiology and a discussion with the surprised family who didn't know that they needed a G-tube, the surgery is finally scheduled days later. Obviously, there are many opportunities for improvement in that process. We launched a single center quality improvement study using stakeholder interviews, consensus building, agreement on best practices, and process mapping. First, stakeholder interviews were conducted with the providers and families to identify barriers to timely G-tube placement. First, for the provider factors, consensus was obtained on a standard malrotation and reflux workup, the scheduling and reading of upper GIs, ENT evaluation of the cords, any additional procedures that needed to be performed at the same time, and ultimately, cardiac anesthesia availability. Next, patient and process factors were considered, including open chests, presence of mediastinal drains, treatment for active infections, and discussion regarding the need for enteral access with the family. This discussion resulted in the creation of the G-tube boarding pass. It's one-page, single-sided, and just a simple document for ease of completion. Process mapping was performed outlining the preoperative steps, including the G-tube boarding pass application for the cardiac teams, our pediatric surgery team, and anesthesia. The G-tube boarding pass was implemented in May of 2022. Pre- and post-boarding pass implementation groups were created for analysis. The primary outcomes of our study included time from consult to surgery, ICU discharge, and hospital discharge. Secondary outcomes included 30-day postoperative complications and total hospital costs. Costs were obtained from the hospital accounting department and adjusted for inflation for the year 2023, based on the Consumer Price Index for medical services. The study included 57 total patients. 35 were pre-boarding pass and 22 post. There were no differences in demographics or operative technique between the two groups. With respect to our primary outcomes, post-boarding pass patients universally had significantly decreased days from G-tube consultation to surgery, ICU discharge, and hospital discharge. Notably, this reduced time from consult to surgery by 3.5 days, which freed us up to do even more cardiac G-tubes. With respect to our secondary outcomes, there was no difference in 30-day postoperative complication between the groups. Both frequentist and Bayesian analyses were conducted for our primary and secondary outcomes. Frequentist models demonstrated a significant reduction in index hospital admission length of stay, time from consult to surgery, and hospital costs. While the Bayesian analysis demonstrated a greater than 97% probability of reduction in all of the length of stay metrics and hospital cost when the G-tube boarding pass was used. In summary, Cardiac G-tube boarding pass was a collaborative, single-center quality improvement study. Implementation of the boarding pass resulted in more efficient and cost-effective care for our children with cardiac disease. While we've seen great improvements, this is the data from our first analysis. Completion of the boarding pass with fidelity still remains an issue, and ongoing quarterly analysis will help us identify how to optimize the boarding pass further to improve patient readiness for G-tubes. Thank you, and I'll be happy to take any questions.
Dr. Zamora, how do you account for the decrease in length of stay and ICU stay post-operatively?
So I think many of these patients, I would say about half and a half start off in the ICU, and about the other half are in the cardiac step-down unit. So for those that post-operatively have to move to the unit, they often remain intubated, and so there's a couple days where it takes time for them to extubate the babies that accounts for a little bit extra stay in the ICU, but ultimately it's much more decreased. In our anesthesia group, all the babies have to have A-lines and multiple IVs for the surgery, so all of that just kind of factors into additional length of stay in the unit before they can go down to the step-down units.
Okay, great. And as a second question, in one of your key driver diagrams, it showed that patient education, family education was one of the barriers. Have you done something from that regard to help with your boarding pass?
Yes, we thankfully have a wonderful team of PAs that does all of our G-tube teaching and education with our families, with the G-tube dolls, the Mickey dolls, and everything. And so they do education with the families prior to discharge. And that thankfully has been a fairly easy process where the cardiac teams let us know this baby's going home, and we'll do discharge teaching that day before they go.
Okay, great. Well, thank you for your presentation. Oh, sorry.
That's question. Program chair gets to ask a question. So quick question, you may not know the answer to this. How do your cardiac surgeons feel about the timing of this G-tube in relation to their initial surgery? How does it weigh in with the Society of Thoracic Surgery data?
At least for our cardiac surgeons, as long as the chest is closed, their wound is their biggest concern. So as long as there's not a wound vac on it and their mediastinal drains are out, they're okay with us proceeding. The other thing, if they're treating for mediastinitis, that needs to be complete before we do the G-tube. But I don't know if it counts for their stats, because I know that, again, my group all talks about many years ago, they actually used to do the G-tubes at the same time as the cardiac surgeries. So I was like, that has at least changed as a practice shift. Yes.
Well, thank you very much.
All right, next we have Dr. Shannon Cram from Boston Children's Hospital presenting development and utility of a comparative performance report card for infection prevention and antimicrobial stewardship in children with advanced appendicitis.
Good afternoon. I'm grateful for the opportunity to present our work on behalf of the Eastern Pediatric Surgery Network. I have nothing to disclose. Appendicitis is responsible for the greatest relative burden of surgical site infections among all pediatric surgical conditions and is responsible for the third highest number of antibiotic days of therapy in hospitalized children behind pneumonia and cystic fibrosis. However, no benchmarking data currently exist to help hospitals identify and prioritize quality improvement opportunities for surgical site infection prevention and antimicrobial stewardship. We hypothesized that variation would exist at the hospital level in both rates of organ space infection and antibiotic utilization, and that variation could be leveraged using the principles of positive deviance to identify performance outliers, hospitals with opportunities for quality improvement, and those with exemplary performance from which best practices could be identified and disseminated. The objective of this study was a proof of concept analysis evaluating the utility of a balancing measures benchmarking report for hospitals' organ space infection rates and antibiotic utilization in children with complicated appendicitis. To accomplish this, we obtained NISQUIT pediatric data from 16 hospitals participating in the Eastern Pediatric Surgery Network. These data were then supplemented at each center with chart review to collect operative report data and antibiotic utilization data. The operative report data was used to define appendicitis severity based on the presence of previously validated intraoperative criteria of complicated disease. Children ages 3 to 17 with complicated appendicitis who underwent appendectomy over a 5-year study period were included. Outcomes included hospital-level rates of 30-day postoperative organ space infection and antibiotic utilization, defined as the sum of the total number of antibiotic days of therapy in the postoperative period. Hospital-level observed to expected ratios were calculated for each outcome, adjusting for a hospital's patient demographics as well as disease severity case mix, including the number and relative distribution of the validated intraoperative criteria of complicated disease. Performance outliers were defined as those hospitals whose 95% confidence interval for the observed to expected ratio for a given measure did not include 1. 1,790 children with complicated appendicitis from 16 hospitals were included. The overall organ space infection rate was 15.6%, and the mean antibiotic utilization data in the 30-day postoperative period was 9.5 days. Variation among hospitals observed to expected ratios for organ space infection are presented in this slide, with the unadjusted organ space infection rates included above each hospital's ODE bar. The ODE ratios ranged 5.7-fold, from 0.5 to 2.8. 19% of hospitals were outliers, with 1 having lower than expected and 2 having higher than expected rates for organ space infection. The variation among hospitals observed to expected ratios for cumulative 30-day antibiotic utilization are shown in this slide, with the unadjusted means included above the ODE bar. The ODE ratios range 2.4-fold for antibiotic utilization, from 0.6 to 1.5. 50% of hospitals were outliers, with 3 having lower than expected and 5 having higher than expected antibiotic utilization. Hospital observed to expected data for both organ space infection and antibiotic utilization are presented here in the scatter plot as balancing measures, with each data point representing a single hospital. The ODE ratios for organ space infection are presented on the x-axis and antibiotic utilization on the y-axis. 25% of hospitals were identified with exemplary performance, 1 which had lower than expected rates of organ space infection, and 3 which had lower than expected rates of antibiotic utilization. 38% of hospitals were identified as needing improvement, with 1 having higher than expected organ space infection rates, 4 having higher than expected antibiotic utilization, and 1 having higher than expected ODEs for both measures. These data must be interpreted in the context of our limitations. This was a retrospective analysis and therefore subject to misclassifications. We also may be underpowered to detect all performance outliers, particularly at hospitals with lower sample sizes. However, the analysis was able to differentiate performance outliers for both measures, establishing its proof of concept for utility as a benchmarking tool. Despite these limitations, this analysis demonstrated that a benchmark balancing measures report has utility for identifying and prioritizing quality improvement efforts among hospitals for organ space infection prevention and antimicrobial stewardship. A report card based on these measures may have great utility in improving the care of children with complicated appendicitis through comparative performance reporting, as well as identifying opportunities for improvement and exemplar centers with best practices. I'd like to thank our collaborators, and I'd be happy to take any questions.
Well, thanks so much for this really interesting study, and certainly, complicated appendicitis really impacts all of us, and we can all do better to figure out what the best way to treat it is. My question to you is that, when you were looking at antibiotic utilization, did you take into account the type of antibiotic that was being utilized?
In this analysis, we limited it to having complete colorectal coverage, but otherwise did not adjust for the type of antibiotics that were used, which does vary widely across centers.
And then my other question was, when we say exemplary with regards to antibiotic utilization, does that just mean in terms of what exactly does that mean? Does that mean we did not use it as much as we were expecting, or does that mean we used it just the right amount?
That's a great question. So the way we're defining it here, it means those hospitals that had lower than expected utilization meaning the total number of days that a child received antibiotics in that 30-day postoperative period compared to the benchmark across all centers. So if we think about it as a principle of antibiotic stewardship, those hospitals are using less antibiotics in kids, and that's the benefit of sort of a balancing measures report, is that you're checking that those hospitals that use fewer antibiotics aren't then suffering higher organ space infection rates.
All right, thank you so much for your time.
Thank you all.
Next, we welcome Dr. Frazier from Children's Mercy in Kansas City. He'll be enlightening us about the current burnout and work satisfaction among pediatric surgeons.
Well, good afternoon. Thanks for allowing us to be here, and thanks to APSA for allowing us to call this to attention. Obviously, you'll hear the next talk as well in the session after this focuses on burnout and wellness. So this is something we definitely need to focus on because it's endemic. Burnout itself, like I said, it is endemic, and we're seeing it more and more, right? It's defined as emotional exhaustion, depersonalization, a low sense of accomplishment, or personal accomplishment due to work-related stressors. It affects job performance, patient care, and us as physicians, we're actually at an increased risk of feeling signs and symptoms of burnout compared to other occupations. It comes with other things, depression, anxiety. We as physicians have an increased risk compared to the general population of committing suicide. And it's not something we can ignore. There's not really any new current data. The most recent data that we have on pediatric surgeon work satisfaction is from 2010. That actually showed that there's about a 96% overall work satisfaction, job satisfaction in pediatric surgeons. And so we sought to kind of establish a baseline in the Midwest Pediatric Surgery Consortium of this, and then follow that over time. And to do this, we created a prospective longitudinal study of pediatric surgeons in the 11 centers in the consortium. And we sent them surveys every 6 months for 3 years. These were validated surveys, and they measured burnout and wellness across several different domains, including burnout, work engagement, and work-related stresses. There was self-reported demographic data from the participants. We summarized that and then calculated the completion rates. So this survey began September 2019. Subsequently, after our second survey in March 2020, COVID hit. So we decided it was important to actually continue the surveys because it was the number one important topic, but we wanted to also then add some COVID-specific questions to this to see the impact of this on our participants. And that happened in September 2020. We sent a total of 738 surveys to 131 surgeons over the 3-year period, and it averaged 124 surveys that we sent due to attrition as well as people moving institutions. On average, 57% responded to the surveys, with for a 74% peak at the first survey and a 47% low at the last survey. In all, 87% of surgeons completed at least one survey. Thank you to those that are out there that I see. In all, 30% completed at least, or completed all 6 surveys, and 23% completed one survey. Academic rank was relatively evenly distributed across all the ranks, and there was not really a difference over time and did not necessarily change over time. And it didn't change based on those that completed all the surveys and those that did not. With regards to the COVID-specific questions, in this Midwest group of pediatric surgeons, nearly 60% reported that they did not feel moral distress due to the pandemic. But what we did find, though, is that those that reported moderate to severe moral distress, that increased as the pandemic progressed. We also found, too, that financial concerns, financial worries, initially started out very high, and that actually decreased as the pandemic progressed. Now, this was a 3-year survey of 700 and some responses. And so we can't go through all of our results here in this 5-minute talk, but I wanted to focus on two things here. One of those is job satisfaction, and the other one is burnout, emotional exhaustion. Overall, when you look at this, when you ask a pediatric surgeon, are you satisfied with your current job, through these 6 surveys, it was actually fairly consistent through the responses. And we found that over 80% of pediatric surgeons in the Midwest Consortium responded that they were satisfied with their current job. Now, comparing that to burnout, and burnout emotional exhaustion question here is that I feel burned out from my work. We found that 89% of pediatric surgeons reported some degree of burnout. Now let's drill down on that a little bit more. Now 30% of that showed that pediatric surgeons reported burnout once a year or less. 20% had reported that they felt burnt out once a month or less. 24% a few times a month. 7% once a week. 6% reported burnout a few times a week, and 2% every day. So obviously this is significant. Looking at this in a little bit of a different way and how we measure, what is the significant levels of emotional exhaustion and burnout, the bottom parts there actually show that. So those ones, that amounts to 15% of the population, had significant levels of burnout, very concerning levels there. So this is not without limitations, right? This is a select group of pediatric surgeons in academic centers in the Midwest. So the effects of COVID are going to be different that we experienced in the Midwest than those on the coast or in other areas. So we don't want to discount that. And also, this doesn't represent private practice or other groups as well. And so I think that's something we need to definitely be cognizant of. But two, we did have limited survey responses, which is in line with the survey science, but that could represent survey fatigue, burnout from people who just don't want to fill out burnout surveys anymore. Or there's other causes there too. But all in all, we know that overall, this group of pediatric surgeons reported good overall job satisfaction, but the majority reported some degree of burnout, and a good percentage of those had concerning levels of burnout that they reported throughout this study. So this really says we need to do something about it, and I think we'll hear more about that as the day continues. We need to recognize it, we need to be aware of it, we also need to do things to kind of work towards developing resources for that. And again, you'll hear about that later on today, I think. So thanks, I'd be happy to take questions.
Dr. Frazier, has the consortium been able to implement some strategies? I know we all talk about burnout at our institutions. They mention burnout, but I feel sometimes when it comes to implementing and making something sustainable that we have opportunities there. I was just curious if the consortium has been working on anything along those lines.
Yeah, that's a great question. That's the next step in all this. First, you have to kind of identify and quantify the problem, and I think that's where at this stage is at. And then next, find resources to be able to do that. This obviously, all of this was completely anonymous, but it was linked to each person, so you could theoretically see that. But that's the next steps that we need to do as a institution, society as a whole.
Thank you. Next question.
Greer Arthur, New Brunswick, New Jersey. I applaud you for looking at this as a very important topic. I wonder if we have an established definition of burnout yet. Because somebody who's burnt out once or twice a year, I'm not sure if that's just a bad day or is that a true sign of burnout. And clearly, these surveys could, if you're having a bad day, you may fill it out more harshly than if you're not having a bad day. So I wonder if you have a comment on that.
Yeah, I think that's a very valuable point. Number one, there's kind of various definitions of burnout. There's emotional exhaustion, there's burnout, there's callousness, and those things kind of come into the different definitions. What we were trying to do is kind of follow this over time, and that's why we did the 6 surveys. But again, that's 6 specific dates and times, and it depends upon the day you're filling it out and how you're feeling, and it's not perfect, right, by any stretch of the imagination. It's as good as that we were able to kind of do, but I think your point is very valid. The only thing I would challenge on that too is if that person say is having a bad day, what's that threshold? What does that mean? Is that bad day going to be a really bad day for you, and are you just going to move on to the next, or is there something else that's going to happen with that and it's going to put you into a really bad spot? So I don't have the answers to that. I don't know if anyone does, but I think it's just something we need to be aware of.
We have time for one quick question.
Great, I had 2 questions, but so Tori Meyer from Austin, Texas. Is this a measure of being a busy professional, this level of burnout? Have you done it? Do you have any idea compared to a lawyer in this same sort of professional trajectory or anything? And then the other question is age. Did you look at age and impact on level of burnout? Because it seems like things are changing with younger physicians, a little more awareness of this issue.
Yeah, so answering that second question first, we did a surrogate for that, would be their academic rank in years in practice. We didn't have people report gender or age or anything like that to keep it very anonymous or remain anonymous as we could. But we found that actually the ones that identified as professors had a little bit lower risks of emotional exhaustion, a little bit less time on the EMR, and felt a little bit less COVID effects with regards to that. As far as comparing to other, quote-unquote professional occupations, there is some data on that. Most of what we looked at is comparing to the general population, but everyone does experience, obviously, the different things in different ways. But again, a lot of the research and data now coming, especially because of the COVID pandemic, and light has really shown on the medical profession, as it were.
Well, thank you very much.
Thank you.
All right, now we get to hear from the fellow perspective with Dr. Krista Lai from Halifax, Nova Scotia, Burnout and Pediatric Surgery Fellows, Prevalence and Associated Factors.
Thanks for the introduction. I don't have any conflicts of interest to declare. So, as a friendly reminder from the last talk, burnout is a syndrome of emotional exhaustion and depersonalization. Among healthcare professionals, it can lead to compassion fatigue, career dissatisfaction, depression, and suicidal ideation. This issue has garnered increasing attention over the last decade, and in 2009, a landmark study by the American College of Surgeons surveyed nearly 8,000 practicing surgeons, and they found that burnout is the single greatest predictor of satisfaction of career and specialty choice. For pediatric surgeons, that study, and as we've already heard, pediatric surgeons are among the least likely to be burnt out. And relating to trainees, the current literature would suggest, as a whole, they are more burnt out than attending surgeons. So to quantify burnout, the Maslach Burnout Inventory is a validated survey tool used to do so. It is comprised of 22 questions organized into 3 subscales: emotional exhaustion, depersonalization, and personal accomplishment. And each subscale measures different types of feelings associated with burnout, as indicated in the quotations, straight from the creator of the Maslach Burnout Inventory. So the goal of this study is to characterize burnout among pediatric surgery fellows. We did this with an electronic survey, including the Maslach Burnout Inventory, as well as demographics and training environment. This was distributed through email and group messenger to 3 years of trainees, the 2 current fellowship years, as well as the recently graduated year at the time of distribution. A total of 126 surveys were sent out with 52 responses for a response rate of 41%, and the basic demographics are listed to the right here. Approximately 54% were second-year senior fellows, 83% were aged 30 to 39, and 71% identified as female. Most were married or in a committed relationship, and over half, 63%, had children. When asked, did you have family that accompanied you to your fellowship training location, about 40% of fellows said no. And 80% had to move fairly significant distances to a neighboring state or province, or even further. When we look at call schedules, 48% took 1 and 2 or 1 and 3 night call, 50% took home call, 64% took in-house call, and 40% reported having a resident or intern in-house. And 81% reported having 5 to 6 hours of sleep per night during their training years. When we examine the Maslach Burnout Inventory responses, the 3 subscales are represented in this slide. And I will note that for emotional exhaustion and depersonalization, higher numbers mean more burnout, versus personal accomplishment, lower numbers mean more burnout. And there are certain cutoffs that are considered for what is high for each subscale based on current literature out there. And in our study, 42% scored high for emotional exhaustion, 35% scored high for depersonalization, and 14% for personal accomplishment. There was also no significant difference between years for the median scores for each subscale. On regression analysis, certain factors were identified as contributory to each subscale. So for emotional exhaustion, hours slept each night in home call reached significance for emotional exhaustion, while history of depression and anxiety approached significance for depersonalization and personal accomplishment. Other highlights from the data would include the coping mechanisms reported by fellows, and by and large, fellows favored sleep and family time. I should also note the low rate of formal mentorship that was reported by fellows. We do acknowledge that this study has limitations because of its small numbers, but also the potential for bias because it is a survey study. And there's also numerous factors that play into burnout that we couldn't explore in this survey because our goal was to make it brief to maximize participation among already very busy fellows. So when we take this into account, we know that burnout is dynamic and complex. The importance of family and support systems in mitigating burnout has been well documented, but a 2010 report from APSA from a survey of pediatric surgeons and their partners indicated an extremely high percentage stated that work was detrimental to their family lives. So it's worth remembering that in this study, 40% of fellows didn't even have family that would accompany them to their training locations, so that potentially puts greater strain on that work-life balance. And ultimately, the reason for characterizing burnout in fellows is to identify practical solutions. And sleep here was an associated factor as well as a coping mechanism. So I think that's a target. So for example, decreasing administrative and non-clinical tasks that add on to an already long day could give back some of that time for the sleep and family time that is so important and valued by fellows. So in conclusion, pediatric surgery fellows experience burnout primarily through emotional exhaustion and depersonalization, and lack of sleep and home call were found to be contributing factors. And often used current institutional strategies are not aligned with what fellows value. I really thank you for your time and attention to this matter, and I'd like to acknowledge all the co-authors at Phoenix Children's for their work on this, especially during my time as a research fellow there, and I'm happy to take any questions or comments.
Thank you so much for presenting this really important topic. You know, I was really impressed. Actually, you know, 40% for a survey response is actually fairly robust.
It's in line with what's out there for survey studies, so thank you to all the fellows who filled this out.
Even though they were tired.
Yes.
Sure. But I noticed that there was 71% that were female, which does seem to be a little bit higher than you know, what our fellow component may actually be right now. And so my question was if there is a significant component of survey bias that's involved in this. And also, while family time has been shown to mitigate it, do you think that can also be a potential risk factor as well? Because I know many people, in addition to you know, the strains of work, then have to go home and potentially take care of their children. And so is that not also a potential risk factor?
Absolutely, 100%. With regard to the first question about female versus male identifying in the survey, one of our factors put in the regression for the factors associated with each subscale was gender identified on our survey, and we found no significant difference between female and male identifying. And then you bring up a really good point about family life also having the converse effect, and I think that if this were to progress into further studies, which I think it should, doing qualitative proper studies, evaluating that to really tease apart that interplay between family life and its protective versus aggravating nature would be really important. So I don't have a great answer for that within the confines of the time today.
And then were there any differences in the programs themselves? You know, for instance, if it was a single versus double fellow program, or you know, if it's home call versus in-house call?
Mm-hmm. Home and in-house call were also put into our regression analysis for the subscales, and there was no difference there. But in terms of single versus double fellow program, that was not put into our regression analysis, but just anecdotally from the data, there probably are not enough single fellow programs to be able to do that analysis, as the majority of programs are double fellow programs from the US.
All right, thank you so much.
Thank you.